Some of you, my name is Khalid Jat. Some of you may know me from before, from the same seminar. So Dr. Hickey, who is your usual facilitator, she is not able to make it today, so that's why I'm here. Um, so I would like to introduce Dr. David Conn, who is our presenter today. Dr. David Conn is a professor in Department of Psychiatry, University of Toronto, and geriatric psychiatrist at Baycrest. Until recently, he served as Executive Vice President of Education and Chief Academic Officer at the Baycrest Academy for Research and Education. Dr. Khan is a founding co-chair of the Canadian Coalition of Seniors Mental Health and past president of the Canadian Academy of Geriatric Psychiatry. He is the author or co-author of more than 100 publications and is the co-editor of 3 textbooks, including Practical Psychiatry in Long-Term Care Home. Um, He has received numerous awards, including the Canadian Academy of Geriatric Psychiatry Award for outstanding contributions to geriatric psychiatry in Canada, and the Distinguished Service Award from the International Psychogeriatric Association. Today, Dr. Khan will talk about social isolation and loneliness and Canadian clinical guidelines on social isolation and loneliness in older adults. Please welcome Dr.
Great.
Khan.
Thanks so much, Khalid. It's great to be here and I see a few friends and colleagues on board today from Toronto, but I don't know the rest of you. If you could just put in the chat just where your name and which program you're associated with in Canada. So it's a great thing, I think, that all the residents from across the country are having a chance to meet together periodically and to learn together. So I think it's a wonderful initiative. And I'm just going to bring my chat up so I can see. John is from UBC. Thanks. Nice. Welcome aboard. And well, if Jenny from U of T, hi. That's great. Don't be shy. I won't ask you too many hard questions. And there's Ari from Toronto as well. Danusha. Okay. Hi. Looks like Toronto's dominating today. Hope some of you are from other parts of the country as well. From Dow. Excellent. Hi, Claire. Good to see you again. Super. Yeah, the rest of you can add your name and where you're from. That'd be fantastic. Okay, I'm just going to bring up some slides. There we go. Okay, so yes, it's a really interesting topic that we're going to focus on today, the whole issue of social isolation and loneliness. As you probably know, the Canadian Coalition for Seniors Mental Health came out recently with clinical guidelines. So we're going to talk a bit about the topic itself and then go through the guidelines themselves and hopefully discuss how they may be relevant to psychiatric practice. And a land acknowledgement just to say that we at the CCSMH recognize that the work to develop these guidelines takes place on many Indigenous territories, including the traditional and ancestral homelands of First Nations, Inuit, and Métis peoples. And these territories may be under treaty, unceded, or contested. And we're committed to advancing reconciliation and equitable health outcomes for all Indigenous peoples. I don't have any major disclosures. I do have some grant funding from a number of agencies and honoraria from this project. And just to say that the anonymous foundation that funded these guidelines has actually become non-anonymous recently. They've decided they don't mind people knowing who they are, and they're called the Walton's Trust, Walton's Trust. And I'll mention them a bit later. Hoping, though, by the end of this talk that you'll be able to list the risk factors and negative health impacts associated with social isolation and loneliness, be aware of the main recommendations from the guidelines, and be able to reflect on how you can assess factors that contribute to this, and then recommend appropriate interventions for your patients. So the CCSMH has been around for over 20 years now, and if you're not actually an affiliate member of CCSMH, it's completely free. All you have to do is go to the website ccsmh.ca and sign up as an affiliate member, and then you'll get all of our materials. And it would be great if you would do that if you haven't already. And the claim to fame for CCSMH, well, there are many, but the number one, I think, is the development of clinical guidelines that date back to the early 2000s, and initial guidelines on depression and delirium and suicide prevention and long-term care. And then over the years, revisions to the substance use disorder guidelines. And then more recently, the release of the guidelines on anxiety, this one, and then on BPSD as well. And I think you're having talks on the other two recently released guidelines. So I think that's great. So we talk about these two things, these two concepts together. Almost always together, people talk about social isolation and loneliness, kind of rolls off the tongue, but they are two different concepts, closely related, but I think it's important to be aware that they are different. And one's objective and one's subjective. So the social isolation is objective. So that's measurable. It's a deficiency in the number of social relationships that a person has. An objective deficit in connections to family, friends, or the community. So you can measure this while recognizing that people have different needs. It's not like everyone needs maximum amounts of social isolation, social connection. There are differences. People have different feelings about what they want. But so loneliness, though, is much more subjective. So it's an internal experience. It's unpleasant. And it's when the person feels that their social relationships are lacking in quality or quantity. Notice that, quality or quantity compared to what they actually desire. So that's actually quite different than just saying, Mrs. Jones only sees people once a week. That may be enough for Mrs. Jones, but if she feels lonely, even though she has many friends and contacts, then that's also very important for us to know. So it's become a big topic. You could call it, it's been called a geriatric giant, one of the new geriatric giants. And all around the world, there seems to have been a focus on this in recent years. The United Kingdom announced a federal minister for loneliness, if you can believe that, in 2018. And that was to add to their campaign to end loneliness, which was already in play at that point and was actually developed around 2012. So they jumped on board. The United Kingdom jumped on board very early in regard to this, and they've taken it seriously at the federal level, and they've put money into it. So, and as you see, it's focused on loneliness. It doesn't actually mention social isolation, which is interesting. They focus on loneliness, that painful feeling. And then other countries, Australia, Japan, Netherlands, and others, the United States, have since declared national strategies to address social isolation and loneliness as a significant health risk, okay? And so it raises the whole issue of whether a social concept like isolation and loneliness is also a health issue. And is social health the same a significant part of health as a whole. I think those of us in psychiatry would say for sure it is. Very recently, the WHO named social isolation and loneliness as growing public health and policy concern. And they created a commission recently with leaders from across the world to look at this issue. And if you do surveys, about half of Canadians will report themselves as isolated, lonely, or both. That was pre-pandemic. That's 2019. It's a pretty high number. This is Mother Teresa. She said that the most terrible poverty is loneliness and the feeling of being unloved. And then the Surgeon General of the United States, Vivek Murthy, he's soon to be not the Surgeon General under Trump, but he actually has served several terms as Surgeon General. But he said, and this has been a big topic for him, he said that we live in the most technologically connected age in the history of civilization, and yet the rates of loneliness have doubled since the 1980s. So significant concern. And these are some important documents. So actually on the third one over from the left is the Surgeon General's advisory on this critical issue, came out in 2023. And as you'll see later on, he actually has 6 pillars under this particular report for improving the situation, one of which is within the health sector. It's a critical issue for the health sector. And previous to that, the National Academy of Sciences, Engineering and Medicine came out with an excellent report on this topic, subtitled Opportunities for the Healthcare System. That's a great document. And then the National Institute of Aging in Canada, not the NIA in the US, but the NIA here, has produced a number of really good documents on this topic. And then the one on the far right is from the UK. It's Promising Approaches to deal with loneliness in later life. So not surprisingly, the rates of loneliness increased significantly during the pandemic. So in all age groups, all seniors groups, and this is from the Canadian Longitudinal Study on Aging, who've done measurements over numerous time periods. And you'll see big jumps there, especially for, well, across all individuals, but the reported rates of loneliness are higher in women than men generally. And you'll see quite an increased rate there on the third column along, which is 2020. So during the pandemic. Not surprisingly, I think all of us got to experience social isolation during the pandemic to some degree or other. And I think we all found it pretty difficult and unpleasant, and the restrictions were quite impactful. And some of us experienced some degree of loneliness associated with that. So Frieda Fromm-Reichmann, who is a German-American psychiatrist, back in the 1950s wrote on this topic. And this is a quote. So she said that there is a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject. And thus it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena and is not even mentioned in most psychiatric textbooks. And she goes on to say that loneliness seems to be such a painful, frightening experience that people will do practically everything to avoid it. So here's a quiz question for you. Is loneliness included as a criterion for any mental disorder in the DSM-5 TR? Anyone want to hazard a guess?
I don't think so.
Okay. Anyone else? Well, it's a slightly a trick question, because you would think from what I've said already that the answer is probably no. And ta-da! Okay, there's the answer. Okay, so it's only mentioned once, so it's almost not at all. It is one criterion within the prolonged grief disorder, of which there are 8. And that's not a lot when you consider how much is mentioned in the DSM-5. So I think Frida from Reichman, I think, was pretty correct in saying that we've tended to ignore this topic, and probably mistakenly. So it seems that isolation and loneliness are not very good for our ongoing health. So there's a lot of research that's been done on this. And you'll see some, rather scary numbers here. So again, these are associations. Obviously, you can't say that it's a direct cause and effect, but there's no doubt that people who are isolated and lonely seem to have much worse health outcomes, and lots of very significant physical diseases. The risks are higher. Sort of thing you might see with depression, right? Their outcomes for depression in the long run are not that great. There are increased risks for all sorts of things associated with depression, but increased risk of developing dementia, that's quite interesting. I don't know if some of you have seen the Lancet Commission's papers, on preventing dementia, which is really, really important. And in their update, 2024 update, they, for interventions in later life, the largest bubble is social isolation in terms of preventing dementia. So that's, that the Lancet Commission document, I think, has garnered a lot of attention. So that's a very important one. And there's an increased risk of death associated with it. That's pretty scary. So this is something. It's because of this, I think, that because of this data that governments and national agencies have said, this is an important topic. It is something that we should pay attention to. And I think it's been likened, to 15 cigarettes a day type thing. Someone's tried to measure that. So, okay, all right. If we accept that as fact, that there is this strong association, then how do we explain it? Does it make any sense? And this is a very simple diagram that suggests that there may be ways of understanding this that are multifactorial, that could relate to less healthy lifestyles in people who are isolated and lonely. That makes sense. Perhaps people drink alcohol more, smoke more, exercise less. Then associations with depression. So of course, there's strong associations with mental health problems, with mental illness, such as depression, and the negative outcomes associated with that, including biomarker changes. So we know about all the associations with inflammation and gene expression, neuroendocrine changes, and so on. So now we're looking more biologically. So it could be that this is a biopsychosocial impact. Even less adherence and compliance to medical treatments, so if you add it all together, it sort of starts to make sense. Yeah, this could make sense. And this is from the New England Journal of Medicine. So it was a commentary from 2023 by Julianne Holt-Lundstad and Persnoto, who are leaders in the field. And I'll read it out because it's quite persuasive. They say that social isolation and loneliness are rarely listed on death certificates, and yet they may have contributed to the excess deaths from all causes observed during the pandemic. And although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support to integrate screening, interventions, and referrals for social isolation and loneliness into their existing responsibilities. patients' lives may hang in the balance. Strong stuff in the New England Journal. And so that led us to this whole idea of creating clinical guidelines. And believe it or not, no one has actually created clinical guidelines on this topic anywhere in the past. And so, and just a word about how it actually came about. So I mentioned this foundation called Walton's Trust. So they approached CCSMH. I guess it was about 3 years ago now, and they said that that we think this is a really important topic, and we're funding projects in this area, and we think we're wondering if you guys might want to do something in this area, and let's talk about it. So we had these ongoing discussions with them. This is really unusual. Like normally, when you're trying to get money, you for a project, you do everything you can to put in a proposal, and you beg, steal, and borrow, and try to come up with the most persuasive argument. And in this case, it was a true dialogue about what could help, what could we do, and it was after a lot of discussion back and forth that we came up with the idea of creating clinical practice guidelines, which they really liked, and then off we went. And the primary audiences are healthcare and social service professionals. Normally, in our guidelines, we'll say healthcare professionals, but in this case, we deliberately added social service professionals who may be outside of the healthcare system, but still doing really important work in the community as key components or members of this target audience, primary target audience. And then, other target audience, of course, we want to help older adults and their families, care partners understand this as an issue, and even policymakers and administrators. This was the working group. So there were a mixture of clinicians and researchers. Amy Friedman's a primary care physician in Toronto, and we have some academics from across the country, and some with social work and nursing backgrounds. And it was a really great group to work with, really committed. And some reviewers and research associates and our staff from CCSMH who were really instrumental in moving this along. And some of you may know Claire Chaplin, who's our executive director, and she's just terrific. And we also, as part of the process, we did 2 national surveys. We surveyed healthcare and social service professionals from across the country and got 350 responses. And then we surveyed older adults themselves and got over 2,000 responses, which helped us understand their perspective on this issue. And it was really helpful getting both of these surveys as we went on to develop the guidelines. We used the grade methodology. I won't go into this, but it's partially based on certainty of evidence, but it's also based on the balance between benefits and undesirable effects, and the actual resources that might be associated with management options, as well as client values. Patient and client values are all taken into account in the sort of classic grade methodology. For some of our recommendations, usually you clarify the recommendation in grade as if it gets in, it's either a strong or a weak recommendation, or some people use the word conditional for weak. But some of our recommendations are actually consensus based. So we were not able to grade them per se. So we had this category for recommendations that are not primarily based on empirical evidence, but rather on the consensus of the expert working group. We go through all the usual activities required with doing clinical guidelines, looked at all the literature, academic and gray literature, and we did also a review of reviews. There are actually a lot of reviews on this topic, so that they were very helpful. So we tried to incorporate up-to-date reviews as well. We did find that the research on interventions is highly inconsistent. regarding the methods, outcomes, settings, delivery modes, etc. And as I noted previously, we were unable to identify any existing guidelines. Again, if you're doing guidelines and you can identify, 6 great guidelines that you just want to update, then that's an easier process. As we were putting together the working group, Peter Huang got in touch with us. Now, he at the time was a geriatric medicine resident in Alberta, and he said, "Oh, look what I've just done, and I'd love to participate in your project." And this hadn't been published yet, but it was almost on its way to publication. So he'd actually done a systematic review and meta-analysis with his team, and it was really well done. So this was brilliant, and it was right up to date. So we welcome Peter with open arms onto our working group, and he's been a great member and continues to stay involved with our project. I won't go into the details of what he found, but we incorporated these findings into the actual guidelines. So turns out that we came up with 17 recommendations focused on both prevention or on prevention, screening, assessment, and interventions. The summary was recently published in the Canadian Geriatrics Journal, the original full document, and as well as a pocket card you can get from the CCSMH website. And we also published another paper in the European Journal Geriatrics. So, okay, under the area of prevention, we talked about risk factors. We said that professionals should have a knowledge of the major risk factors and, potentially being able to anticipate possible changes in life circumstances that could put them at risk of social isolation and loneliness. So if you can anticipate that someone's, for example, if someone has a spouse who's extremely ill and likely to pass away, then you already know that there's a strong possibility that this could become a problem in the near future. And so you could actually start to discuss that ahead of time even. There's many risk factors associated with this problem, as you can see listed here. And many of them make sense. Now, age is an interesting one. There's no question that older adults experience a lot of social isolation and loneliness, but so do a lot of younger people. And there's quite a lot of recent data that younger adults are experiencing this to a great degree as well, even though they are so socially connected or technologically connected, as the Surgeon General said. So it's certainly not just a problem with older adults, but virtually all minority groups, LGBTQ, anyone who lives alone, being widowed or divorced, caregivers, those with low income, poverty or education, lack of affordable housing, all sorts of health issues, of course, for obvious reasons, mobility issues, sensory loss, a huge one, especially hearing loss, as you can imagine, and certainly leads to a great deal of social isolation. A lot of people don't want to wear hearing aids. Mental health issues themselves, poor health behaviors, small or shrinking social networks, people who are challenged technologically for obvious reasons, and then major life transitions. So all of these are risk factors. There are so many. We highlighted education as a critical issue. We're actually doing some work now trying to get this into the curriculum for students in healthcare programs across the country. Professionals as agents of change. So we thought that we should use our role as agents of change to help inform and educate patients and the general public about this association. With the whole idea, of course, being to promote social connection. Targeted screening. So we recommended targeted screening for those who have risk factors. And as you can see, that was a lot of people. So, we are being reasonable, saying that, targeted is the way to go. We also wanted to highlight the fact that there's a stigma issue here, as with all mental health issues, but some people may not want to admit that they're lonely or feel they're being labeled as lonely, and I think clinicians need to be sensitive to that. And then there are screening tools, quite a bit of research on this. So we said that it's a good idea if you're going to use screening tools, they should be evidence-based, and that they can be used to identify individuals, to assess severity, and to use in routine follow-up. We also made a note here that that the need for social connection is highly variable, and that for some people, for almost all of us, some degree of solitude is a positive thing. So we're advocating a balanced approach to this issue. These are some screening tools, so we document those in the guidelines and discuss those, and the actual screening tools are in the guidelines. Some are short, some are long. Some focus more on loneliness. Some focus more on social isolation. There's a Canadian tool called the CARED, C-A-R-E-D. Nancy Newell was on our working group, actually, but this is a very nice tool that looks at both, and it's designed to identify people who may need help. These are two of the briefest tools. One is a single item tool. It's been studied. And then the most commonly used UCLA loneliness scale, which was originally longer and then reduced to 3 items. And the items are: how often do you feel that you lack companionship? How often do you feel left out? And how often do you feel isolated from others? Interesting, isn't it, that this is a loneliness scale that does not use the word lonely in it. Does not ask if you feel lonely. Isn't that interesting? We recommend that this be documented in health records as a psychosocial vital sign. So that's an important recommendation. And then, of course, we recommend a thorough clinical assessment, looking at the causes, not jumping to conclusions about what the issue is caused by, using a biopsychosocial approach. And I think this is one of our key recommendations, really, because what I hear a lot of is that the solution is always just get people to get out more and do more to connect, and that is the sort of simple answer to this. And it may be the answer, but it's not always the answer. And so, the key components in an assessment, this is not news to any of you, but we do document this. These are things that you need to look at, including lifestyle and motivation for change, because a lot of people may say, yes, I'm somewhat isolated, but I actually don't want to do anything about it, so I think that's important too. And then the overall approach to interventions. So these are the sort of basic principles. So first of all, and very important, certainly for us, for physicians, ensure initially or concurrently that treatment is provided for any underlying medical conditions identified in their assessment. Obvious to state this, but really important. A lot of medical and psychiatric conditions may be contributing. So, if the main issue is depression, then depression needs to be treated. Or if it's a social anxiety disorder, or if the person desperately needs hearing aids, then that would be a good first approach. And then we emphasize, an individualized approach, very important, with shared decision-making, understanding the person's interests to really kind of figure out what may be best for that person and what's available in their community. And then, recognizing the diversity within older adult populations and considering culture and lived experience. And then these are all of the different interventions, and we state up front that there's no, we don't recommend one of these over the other, that they're all things that may help and should be considered. And the pharmacological therapy specifically for social isolation and loneliness is not recommended unless it's for treating some underlying disorder like depression. And these are the recommendations. Social prescribing. There's a real movement around social prescribing. And in Canada, in the UK, there's a Canadian Institute for Social Prescribing that's growing rapidly. There's more funding going into social prescribing. What is it? So it's really linking patients to appropriate resources in the community. Classically, it uses people who are actually employed to do this, who are called link workers or system navigators. We would certainly recommend a stepped care approach, but we certainly recommend that organizations should consider developing social prescribing strategies or teams, and that community organizations should develop relationships and partnerships with clinical organizations rather than the siloing that often takes place. So just wondering if any of you across the country are aware of any social prescribing programs in your communities, anything that's been funded, or do you hear about these link workers? Anyone heard of those?
Yeah, we recently had a Grand Rounds talk in Edmonton, Alberta, about social prescribing and kind of the formal organization that's available. I don't think they called themselves linked workers, but it was almost like system navigators to help seniors understand what resources are available.
Okay, yeah, I know Alberta's actually put some money into this, so that's great. Yeah, some people will think of it as the sort of simple idea is a physician gets out their prescription pad, and writes out a recommendation for more social connection with maybe some specifics. I want you to, I'm prescribing that you should go to your seniors center in the community, once or twice a week and actually give that to the patient. So some physicians view that as a social prescription, which it is. So that's a very simple idea, but that can be helpful too. And then this runs closely in association with that, but we separated it out. And that's just simply that we've got to find the optimal level of social activity for each individual, recognizing that can vary dramatically. And we want to empower individuals to find that and to make that happen. Now, physical activity is good for everything, right? And so there is evidence, there has been research done looking at physical activity in association with, in relation to social isolation and loneliness, suggesting benefits. But, it's good for everything. It's a non-specific thing. Interestingly enough, though, that you'd think group physical activity would be, would be doubly effective, but even individual physical activity seems to help everything as well. So we recommend physical activity, of course. We recommend psychological therapies for some individuals. So depending on, I think individuals who've had sort of lifelong feelings of loneliness can be helped by psychotherapy in particular. And there have been a variety of psychotherapies that have been found to be helpful: CBT, social cognitive therapy, reminiscence therapy, and mindfulness-based stress reduction, among others. So, but it does make sense if you understand that a person's loneliness may be much more kind of an intrapsychic process or something that relates to their view of themselves in relation to the rest of the world, then just telling them to go to their community center is probably not going to make that, it's not going to work. And so, so psychological therapy certainly can be helpful. And if you think of someone with a social anxiety disorder, yes, they might need an SSRI, but psychotherapy in conjunction is almost certainly going to be beneficial. This is the downward spiral of loneliness around negative thoughts and feelings and negative views of themselves, and how that can be turned around into a more positive, using CBT approaches. Animals. So, if you have a pet, you take a dog for a walk in your community, people are going to stop you and talk to you, and people love, chatting. And, I don't know if any of you have animals, dogs, pets, cats, but especially dog walking. It's actually amazing how many people will talk to you versus no one will talk to you if you don't have a dog. It's quite remarkable. And so that led actually to an amazing program in the Netherlands. Now, I love this program. This makes so much sense. But as part of their loneliness campaign, they have an app, and the app allows older people that don't have a dog to connect with younger people who are busy working but have a dog and don't have time to walk it or look after it. And so they become kind of a co-owner. And it's been a beautiful program. Thousands of connections and ongoing relationships have developed. Simple idea, but just, so so animal-assisted interventions in pet ownership, may be helpful for some individuals. Developing leisure skills or recalling leisure skills or coming back to things that a person has known in the past can be really, really helpful. And of course, technology and, it's, as we all know, it is a way of connecting. It's not the same as being, in the same room as someone, but it can be, really, really second best, but still really important. And I think for some older people who are living alone, connecting using interactive video conferencing is great. So, but not all older people know how to use computers, or they forget how to. So we have to take that into account. And so, that there are programs that try to teach digital literacy and help older adults to navigate this. And I think that's a really important approach as well. And this is just, the idea that we don't recommend pharmacological therapies unless there's an underlying disorder. There has been some research going on about the possibility that there may be some, underlying neurobiological changes that could be treated possibly with various agents like oxytocin, but that's very, very limited research on this, and we certainly don't recommend it. And then finally, that, if you're going to help someone stay connected, get them to set goals, reconnect, reassess, help them overcome those goals. This is kind of the fountain of health approach that was developed in Dalhousie. Setting small goals, getting the person to set their goals, and then helping them to achieve those goals can be really, really important and helpful. The guidelines do note that there are special populations, of course, and there are documents focusing on certain diverse groups in Canada, like Indigenous older adults, residents of long-term care homes, people living with dementia, LGBTQ. So these are documents that are worth looking at. Again, a focus on marginalized communities, a lot of research into this. That's a very good document on specifically on older Indigenous individuals from Canadian government. And this coming back to the Surgeon General's document, this is what he wants to see happen: 6 pillars to advance social connection. And maybe it's better to talk a lot about improving social connections than keep harping on on isolation and loneliness. So that's a more positive way of framing this, is that we want to improve society in terms of real social connection and to change our culture. That's what the Surgeon General is hoping for. So there are lots of resources on this topic on our website, and then just some key points, which I don't think I need to go over really, but I think that we are uniquely positioned to help on this topic. And the final thing I want to mention in the bottom bullet there is that this foundation has actually given us more funding, to actually try to implement the guidelines. This is really unusual. It's usually great guidelines, and then you do your best to disseminate them, and then hope things go well. But we're continuing to work on this project now with we now have a National Insight Council that's helping us with some of the individuals from the initial working group, but some new individuals. So we're aiming to I use limited resources, but some resources. We have a little team that's continuing to work on this, so that's really exciting. There's my email address if you have any follow-up questions, issues. If you want to work on this topic with us, we're open to all sorts of ideas if any of you feel passionate about it. And Betty Watson-Borg is our project manager for this. And I am gonna stop now and open it up for any discussion. So comments, questions, ideas. Is it relevant to your practice?
Oh, absolutely. I think that like social isolation probably is quite like over, not focused on enough because especially because when people come to hospital, we're best at focusing on the biological, not the psychosocial factors that
Yeah.
make up why they're there. But just I recently like had discovered that there's like a resource called like it's like Community Without Walls where seniors can like just like call a number or sign on to the Zoom link at a certain time and like they just have like discussions about history and birds and it just was like seemed so cool to me that it's starting to develop and we're trying to use virtual and online modules to get some type of connection for seniors who could be isolated. I think the hardest part is just that people get stuck in doing the same ways that they've been doing for a long time and it can be hard for them to be willing to try something new to make new connections.
Yeah, absolutely. Yeah, and that's why we emphasize the issue of checking in on motivation for change and really making it a collaborative effort and really trying to work with that person from their perspective. And as we do in psychiatry all the time, right? That's what we're trained to do. But of course, our when you're producing a guideline, you want to give as much guidance, if you like, to people who don't necessarily work in mental health or don't have the sort of background knowledge that we do as a group of psychiatrists. So.
Thank you, Dr. Khan. To talk about such an important topic, but less talked about. Um, Social isolation and loneliness may not be the cause or direct cause or linkage for any of the health related issues, but indirectly, as you mentioned, can affect both medical health, mental health. Um, I wonder from last maybe 40, 50 years, um, family size is shrinking,
Mm-hmm.
less family members, less children. People are moving much more, leaving homes for education or work-related issues. Um,
Yeah.
and although there is a much more connectivity, digital connectivity, but there is no similar thing with like a face-to-face connection.
Yeah. No, I think that's critical. And yes, I think, and that's one thing that the Surgeon General of the U.S. emphasizes: just the change, how rapidly our culture has changed, and there's just much more difficult for people to have connections. And I think that's happening to all of us in our workplaces too, by the way, with using Zoom for all our meetings, our educational events, and it seems to me like we're falling prey to this because of the convenience of it. Now when we have an actual in-person meeting, it's like, wow, isn't this amazing? Put together. But for a national webinar like this, it's fantastic because we can. So the technology is wonderful, but it's also a barrier, I think, to more in-depth communication and connection.
And when you're young and adult, when you're fully involved in your careers and work, you don't have time to think about the social isolation and all that. As
Yeah,
people get old and old, especially after retirement, we all know how many people can get significantly depressed after retirement. And then you
yeah,
have more and more times on your hands and nothing to do.
yeah. Yeah, and I think men versus women, there's a lot of discussion about this because women are naturally better at connecting. It's just, this is stereotyping, but by and large, that's true, I think. And men, you know, for whatever reason, first of all, they have more trouble expressing their emotions, their feelings, and at least I think that's true. So there's been some solutions like men's sheds. Have you heard about those? These are where guys get together to do work on some sort of project, woodworking, for example. You know, guys just want to get their tools out and work on something together. But by doing that, it brings people together, obviously, and in a way that's more acceptable, perhaps, than saying we're going to meet to discuss you know, our lives and our feelings. Actually, Movember, they funded a lot of men's sheds as a program. Yeah.
Any other comment or question?
No, just thank you.
Great.
It's helpful.
Okay, great to see you all, and good luck with your training. You guys are both PGY 6s and 5s, mostly 6s, right? Yeah, fantastic.
Fives and six.
5s and 6s, okay, fantastic. Well, good luck with all your training. I hope to see some of you soon, and if not in Toronto, maybe at CAGP, CCSMH meetings, and all the very best.
Thank
Thank
you.
you.
Okay. Thank you, Dr. Conn.
Bye. Have a great day. Bye.
Thanks again.